hosted by the Taubman Center for American Politics and Policy and the Watson Institute. We're really fortunate and thrilled to have an incredibly relevant topic to discuss tonight, and it happens to be the title of a book, Today's Healthcare Issues Across the Aisle. We're going to ask our panelists to participate. We're going to have our two book authors start first, and then we're going to ask the rest of the panel to weigh in, and I'll be moderating and taking your questions and tracking them along the way. So feel free to type them in to the Q&A, and we'll see if we can get to them either in the conversation or certainly afterwards. So I'd like to introduce our panelists. Our two authors are Professor Robert Hackey, who is a professor of health policy and management at Providence College and also teaches public policy at Brown University. And we also have Professor Todd Olszewski, who's an associate professor of health policy and management at Providence College and the co-author of this book. We are also really privileged to have terrific panelists with us. We have Professor Martha Gardner, who's associate professor of history and social sciences at the Massachusetts College of Pharmacy and Health Sciences. We also have Professor Kelly Smith, who's a Brown PhD alum, who's an assistant professor of political science at Stetson University. And we have the legendary Darrell West, I still call him professor from all of his years at Brown University, who is currently vice president and director of governance studies at the Brookings Institution. So we're really thrilled to have everybody here with us. We're going to kick it off with Professor Hackey and Professor Olszewski. They'll talk for about 7 or 8 minutes each, and then we're going to have a moderated conversation and ask the panelists to weigh in, and of course, take your questions as well. So I'll turn it over to Professor Hackey.
Thank you, Wendy. Let me just pull up my PowerPoint to share for everyone here tonight. Hopefully everybody can see that, and we'll get us kicked off here. So again, thank you very much for hosting us. Todd and I are really grateful for the chance to share our work with the folks here at Watson and the larger Brown community. Our volume really speaks to the present moment, where public discourse about health policy generates a lot of heat and a lot of partisan rancor, but often fails to yield any meaningful consensus over how to reform many of the issues that we've explored. Each of the chapters in our volume introduces readers to both Democratic and Republican perspectives on contested health policy issues. We seek to provide students, faculty, and general readers with a clearer understanding of how Democrats and Republicans frame debates over health policy. And furthermore, how these definitions reflect fundamental differences in each party's values and worldview. Sorry about that. So our series, which publishes this book, is a new series from ABC Clio. It's targeting a general readership. One of our principal audiences are college and university libraries, but also we're also hoping the book will be adopted in courses on health policy. And one of the things that the defining principle of this series is that we did not take a stand on the various issues that we explore in the volume. In fact, we were prohibited from doing so by the series guidelines. Instead, our goal is to introduce readers to how each party views the issue. In an intensely partisan time, we're trying to provide readers with a perspective that's grounded in the policy history of each issue that we explore, and it also incorporates contemporary rhetoric and recent developments. But we don't endorse particular points of view or policy solutions. So I'm going to introduce several key themes which run through a number of chapters in the volume as a way of giving you an overview of some of our key takeaways. I'm going to focus my discussion on several distinct but complementary themes. Each reflects different ways of framing health policy debates. The parties, as I mentioned, bring fundamental difference in philosophies, preferred policy tools, and values to address important health policy challenges that we face on a wide range of issues. The first issue I wanted to highlight is that Democrats and Republicans have very different notions of what liberty looks like and how we should think about it. And that really reflects Isaiah Berlin's classic discussion of two concepts of liberty. Democrats tend to embrace what Berlin describes as a positive conception of liberty. And this really focuses on enabling individuals to develop their life goals and potential. And so, for example, with this view, while government mandates to purchase health insurance, for example, or wear masks, get vaccinated, do limit individual choice, they also allow individuals to access healthcare and to return to work or school with greater safety, to reopen the economy. And so even though there are restrictions on personal choice, those are paling in comparison to the larger goals. In contrast, Republicans embrace what Berlin describes as a negative conception of liberty. And in this view, a person should be free to really make their own choices without constraint. And so this is really at the root of much of Republicans' opposition to the individual health insurance mandate, masking requirements, vaccine mandates, social distancing, lockdowns. All of these things really are reflecting a passion for negative liberty. The next issue that really separates Republicans and Democrats is who should make decisions on health policy matters. Democrats and Republicans differ on which level of government ought to be tasked with solving healthcare problems. Democrats tend to favor uniform policy solutions led by the federal government rather than state-based solutions. And the reason is that those state-based solutions often yield significant variation in both policies and outcomes. For example, as you may have heard, the Biden administration last month announced a national vaccine mandate for both healthcare workers and for employees at firms with more than 100 workers. This provoked a severe backlash from many Republican governors, including folks like Ron DeSantis in Florida and Greg Abbott in Texas, who staunchly opposed this policy. Republican governors argued that states ought to be able to decide for themselves what solutions were best suited to their own local circumstances and conditions, and importantly, to their own voters' preferences. And we also see this in the implementation of the Affordable Care Act, where a majority of Republican-led states refused to establish their own health insurance marketplaces, opposed Medicaid expansion, and often supported work requirements for Medicaid beneficiaries that their counterparts in Democratic states did not. A third and important distinction here is that we live in a time of intense partisan polarization. The COVID-19 pandemic has really exposed profound differences in the beliefs of Democrats and Republicans and in their actions. Recent polls by the Kaiser Family Foundation found that partisanship is a key predictor of vaccination status. For example, 60% of unvaccinated Americans either identify as or lean Republican, while just 17% of unvaccinated Americans are Democratic or lean Democratic. Furthermore, 3/4 of vaccinated Republicans and nearly all unvaccinated Republicans view vaccination as an individual political choice. Now, in contrast, 81% of Democrats believe it's everyone's responsibility to protect the health of others. That's a big divide. Deep differences between self-identified Democrats and Republicans are also evident on issues such as the single-payer healthcare proposals, often known as Medicare for All, support for the Affordable Care Act, and various responses to COVID-19, from mask wearing, mask mandates, the severity of the pandemic itself, and vaccination requirements. I think it's notable that recent polls from both the Pew Research Center and the University of Virginia Center on Politics underscored this partisan sorting. Democrats and Republicans are not only disagreeing on policy, but they often harbor intense dislike for their opponents. Before the 2020 election, more than 90% of self-identified partisans polled by Pew worried about the future of the country if the other party's candidate won the election. We are living in seriously divided political times. The last point I wanted to mention as a key distinction between Democratic and Republican views on healthcare is the view of the marketplace and market forces in shaping health policy. For Democrats, markets require careful regulation to protect consumers from profit-hungry firms. Republicans, in contrast, underscore the virtues of markets in promoting choice and in driving innovation. For example, Republicans defended short-term limited duration health insurance policies, which Democrats derided and dismissed as, quote, junk insurance that ought to be banned, on the basis that consumers should be allowed to choose the health insurance plan they felt best fit their needs. Prescription drug pricing also fits the same issue. Parties remain divided. Democrats argue the marketplace for prescription drugs is fundamentally broken and that the federal government needs to intervene to provide countervailing power to advocate on behalf of consumers with drug makers. Republicans strongly oppose this as a slippery slope, a threat to liberty that will ultimately threaten not only the choices available to Americans, but drug innovation itself. And so we see fundamental differences here in terms of how we ought to respond to the market forces that exist in the healthcare system. For Republicans, markets are a way to empower consumers, foster innovation, and lower prices through competition. Democrats disagree. Last but not least, our book hopes to accomplish, or at least be a step in the direction of helping Americans reason together about health policy issues in a more productive way. We really embrace the idea that better conversations about health policy are not only possible, but are in fact necessary. The status quo we face is deeply dysfunctional. In Darrell's recent book, Divided Politics, Divided Nation, he describes the challenges we face in terms of hyperpartisanship. And in his final chapter, he urges readers to take someone with different political views to coffee or lunch to try to develop relationships with individuals outside of their own narrow political circle. Other projects, such as Resetting the Table and Unify America, are trying to do similar things, offering programs to provide opportunities for structured discussions about difficult political issues. We hope that in a small way, our book will be a resource for readers to educate themselves about health policy issues so that they can have more informed and productive conversations with their friends and neighbors across the aisle. Thank you very much. I'm going to stop sharing.
Great. Thank you so much, Professor Hackey. Now we'll have your esteemed co-author, Professor Olszewski, and you have about 8 minutes.
Thank you. And I will share my screen as well in just a second. Okay. Hopefully everyone can see. So first, I would like to thank the Taubman Center and the Watson Institute for hosting this event, Professor Schiller for moderating, and of course our panelists for their insights tonight. I hope to build on Bob's remarks in 2 ways: to offer some comments about our writing process as faculty members at a small liberal arts college, and to highlight how we've integrated our research into our teaching. As Bob already mentioned, our book focuses on a series of contentious issues in health policymaking. One of the challenges, but great opportunities for this book, was its scope. As you can see from the table of contents highlighted here, we've documented a wide range of policy issues, some of which we might not have written about otherwise. And we did so while topics were changing underfoot. As a historian of medicine, I'm not particularly used to documenting events in real time. Since each book chapter addresses partisan rhetoric and policymaking in the present day, I found myself relying on my skills as a historian to track trends in words and action in order to capture what politicians and policymakers were doing and saying right then and place those actions in historical context. Each chapter provides a historical overview of the party's policy records, highlighting how each party frames debate over that particular issue, followed by a closer look at recent debate over the past 2, maybe 3 years. As I think about major questions that cut across multiple chapters, to a certain degree building upon Bob's previous comments, 3 major questions come to mind. First, will the government occupy a more central role when addressing perceived shortcomings of our healthcare system, or will the private sector occupy that position? Second, what obligations do state and federal governments have to their citizens when it comes to healthcare matters? And third, what role will the courts play in expanding or restricting health rights, particularly as the US Supreme Court revisits the Second Amendment and Roe v. Wade? Bob and I were fortunate to recruit more than a dozen health policy and management majors at Providence College to serve as collaborators and co-authors for this project. We sought students who demonstrated strong research skills and openness to critical feedback and polished writing skills. I think Bob would agree that building close mentoring relationships is what enabled us to manage a project like this while teaching at a small liberal arts college. We drew lessons actually from our previous experience collaborating on a report detailing New Hampshire's implementation of the Affordable Care Act for a national network study. In that case, we invited a health policy and management major to work on that report with us. During our initial group meetings, we identified our respective strengths and interests, then worked together to assign research tasks and sections of that report to one team member or the other. By emphasizing the collaborative nature of the work, our junior scholar retained her own sense of independence while also being able to ask for input as necessary. And we sought out her input as well. We applied this model to our team of collaborators for this more ambitious book project. We think of this approach as empowered scholarship by embracing students as co-equal junior scholars with a shared sense of mutual accountability. While we might provide more open or honest feedback than we would for a classroom assignment, we're also sharing ownership of what's on the page. Building our team meant learning how to trust in others and take risks. We assured students that we weren't grading their work, that instead we were partners in this endeavor and that they would critique our writing just as we would offer feedback on theirs. Our student collaborators also served as our eyes and ears and tracked any real-time developments for chapters that we'd already completed so we could update them accordingly before final submission to our press. Teaching at a small liberal arts college means that our teaching obligations often limit what time we have to conduct research. So finding creative ways to connect the two can make both research and teaching more rewarding and, more importantly, more productive. Our book chapters have paid dividends in the classroom as we've drawn upon the book's structure and approach while teaching our department's writing seminar these past 2 years. Because the chapters are built around the fundamental principles driving the parties' respective policy positions, the chapters are not time-bound. Each chapter provides background context for one of our course's module topics. We then supplement the chapter with primary sources drawn from the present day, news stories, public opinion polls, policymaker statements, and congressional records, as well as other secondary sources. We've organized our edition of the course around several of our chapter topics. This semester, we've examined Medicaid work requirements, Medicare prescription drug pricing, gun safety, immigrant health coverage, and at this particular moment, COVID. Students write op-eds, engage in in-class debates, and write traditional research papers that expand upon their op-eds. We encourage the students to carefully consider issues from more than one point of view. And by participating in formal debates, students learn how to formulate and defend a policy position by drawing upon multiple forms of evidence and data. Ultimately, we hope that the book and the course prepare students to become thoughtful and principled future professionals, whether they pursue careers in healthcare, public health, or health policy. And with that, I will stop sharing and turn things back over to Professor Schiller.
Thank you so much. That was a terrific presentation. And I think we all understand how hard it is to maintain a teaching schedule and a research schedule, and also the breadth. I keep looking to my right because the book is right here. The breadth of the topics that are covered in this book. It's sort of a monumental challenge. It's really an amazing product and amazing effort that you put in to produce such a thorough book. So I have some familiarity with the backgrounds of our panelists, so I am going to try to tailor my initial questions to that. But I'm going to start in a general way, Professor Gardner, about the fact that we're actually discussing a book that is so comprehensive about healthcare, but also has the political, partisan, ideological positions of the parties in the same chapter, the same page. And that's somewhat new for us. And so if you could reflect a little bit about the implications of making healthcare political, or maybe that started, with Bill Clinton's healthcare program, or even Harry Truman in the 40s. But how do we grapple with that when we also want to be healthier?
Healthcare, I teach a few different classes. My school is for healthcare professionals. Most of them are going to be pharmacists, doctors, nurses, the whole gamut. And I find that I think that healthcare is political, as everything is already. I don't think there's a way to not make it political. So having it be explicit in some ways is helpful. One thing that I think is really true is that as a historian, as a humanities person at a health sciences school, what I find when I teach classes is they often have a liberal bent, right? The classic liberal arts being a liberal bent kind of place. And my students, however, are not necessarily those who have a liberal bent, right? So to have a book that has both parties in it provides me fodder that I don't necessarily choose otherwise. And I think that that's a very helpful thing. I think policy doesn't work without politics. We have politics in our day-to-day life. We are not going to get policy unless politics works its way through and those policies pass. So we need those politics to be talked about if we're going to move forward with policy. So I think when I think of working with my students, I think a book that has both those sides to it would be useful. And one thing, as just chatting with Todd and Bob about how they use it in their classrooms themselves, one thing I really like is they have students, no matter what side they are on, they assign them to a side as they debate the issues in class, right? So then you have to think about that side, whether or not it is your side, right? And that is a vital thing to do, right? So I think that works very well, and I'm excited about using that. I don't think, and often when I teach my history of medicine class, I have students look at health policy issues through the lens of narrative, like through the ends of people's stories, using Health Affairs Journal often. And what you find is politics and policy and what we have is embedded and surrounded by politics. There's no way to divorce the two. So to me, it makes sense.
All right, that's an interesting perspective, and it's fascinating just even to recognize the disconnect sometimes between faculty who are teaching classes, perhaps, and the students who are taking them. And on that note, Professor Kelly Smith has a really interesting juxtaposition of background, obviously going to school in Providence at the undergraduate level at Providence College, and then coming to Brown for her PhD, and then teaching for several years now at Stetson University in Florida. My question for you is, your expertise tends to be in federalism and provision of services across state lines. What do we think about a country that has such different access, you could argue, to healthcare within a state, within populations, but across states? How do we reconcile these federal policies that are passed? And we think, oh, okay, that'll solve everybody's problem at the local level. How do we reconcile the fact that that doesn't really happen because we have so much authority at the state level over healthcare?
Yeah, well, we can think of it as two sides, the same coin, right? Because in some ways, the federal structure can be limiting, right? We see that states are able to opt out of innovations. They don't have to adopt Medicaid expansion, for example, and this creates a vastly unequal terrain across the United States. On the other hand, federalism gives us a lot of opportunities to pursue the health policies that we want to see happen that might not get passed at the federal level. For example, we see this in the discussion of physician-assisted suicide, right? At the federal level, this policy was not able to be pursued, but we see states taking the first steps in innovating in that area. So in many ways, the federal structure also opens up venues to pursue policy changes. And this is something I try to convince my students of all the time. I feel like when they come in to our classes, and particularly I teach American health policy, and I'm doing so this semester, and the students, are trying to grapple with the landscape of health policy, and a lot of it is focused at the federal level. And so trying to reiterate how much is happening at the state level and how much of the federal policies are actually building upon state and federal relationships, right? That even if we have a policy at the federal level, oftentimes it does have some type of state component where we might see differences in taking up of that policy and differences in implementation and then differences in outcome. And so I think, yes, we have to be concerned about trying to pass healthcare policies and being cognizant of the inequality it might perpetuate across the United States. On the other hand, it's a great opportunity, especially for students who want to see change in these areas, to pursue changes at local and state levels, because there's a lot of power there to make changes in healthcare and public health policies too.
Those are excellent points. I think one of the great features of this book, particularly if you're an educator, but even if you just want to understand the health care system in the United States, is how succinctly you describe so many different programs that affect all American families, whether it's child health insurance, or it's certainly increasingly changes in Medicaid at the state level for what they'll cover for home care services for the elderly. The vast gamut of every person in your family is affected by healthcare, and this book gives you really terrific information about a lot of those different programs, if not all of them. Professor West, who was a terrific mentor to me when I was coming up early in my career and later in my career at Brown, I have a question for you based on what you've seen over the last, let's say, 30 years even. You wrote a terrific piece on the Harry and Louise ads against the Clinton healthcare program many years ago. And of course, you have Air Wars as your preeminent book on the ability of parties to message. And my question to you is, how has the Republican Party, and the authors of this book are very careful to keep their descriptions really solid, right? There's no editorializing in these descriptions of the party's platform. But for your work, who would you say has won or wins the messaging battles in terms of healthcare? And why is there such a disconnect between people who receive government healthcare, either through Medicare, Medicaid, or any other, government-sponsored program, but also identifying as Republican and saying they don't like big government? So is that a messaging failure, or is that just 30 years of culminating messaging failure? If you could talk to that, that'd be great.
Great questions, Wendy, and it's nice to be with you and to be back at Brown University. And Bob and Todd, congratulations on a terrific book, very well timed for this particular era, which, as all of you have pointed out, is a highly polarized era with lots of misinformation. On the question of party messaging and who's doing well, it's hard to say because there are so many different political elements that are going into the current equation beyond the healthcare issue. But on healthcare in particular, Republicans certainly have a simple message that they have hit home. And it seems to have put them in very strong position for the 2022 midterms and possibly even the 2024 presidential election. But I do think in the longer run that some of the things that they're doing are going to backfire on them. I think a lot of people take a status quo orientation to politics and see whatever problems we see today are going to be the same things that we see 5 years from now and 10 years from now. And what I like to remind people is we're actually living in an era of mega change where there is large-scale transformation taking place at a variety of different levels. And there certainly is going to be a lot of demographic changes where the country is going to end up in a more progressive direction, just because young people are much more progressive than senior citizens. And as young people age and move into leadership positions, that's going to affect national political discourse. So for the next few years, Republicans actually are very well positioned. On a longer term basis, they're actually not well positioned at all because they are running contrary to demography. They're running contrary to the way in which younger people are more progressive in their views. And I also like to remind people that it's easy to get very pessimistic about our current polarization, the high levels of misinformation, and to conclude that that's always going to be with us. I like to remind people there actually are positive examples of opinion change and behavioral change in the healthcare area. And one of the best examples of that is public laws, public attitudes, and personal behavior in regard to smoking. I mean, I remember when I was much younger, like many people smoked, there were none of the anti-smoking provisions that currently are embedded in law. And smoking was all over American television and American movies. Like you would watch any show and people smoked all the time. Kind of fast forward 30 years, there's been a revolution in how people think about smoking at the legal level, at the policy level, at the attitudinal level, and at the behavioral level. So do not underestimate the possibilities of change. Things may seem grim now, either in terms of party messaging, polarization, or the high levels of misinformation that we see. It's not always going to be that way. There are trends that are moving in the other direction. Even if Republicans actually win the short-term messaging war, doesn't mean they're going to win the longer-term war.
So that's fascinating. And we have a very good question that I'm going to get to shortly. But I have a question for Professor Gardner and Professor Olszewski on this very thing. I was thinking similar things with what we call public health epidemics. And of course, before COVID-19, which is obviously a pandemic, which looks like it'll be endemic, you know, we had great concern about obesity levels in this country, in particular among children and particular groups, low-income groups. And of course, the enormous healthcare problems that come along with obesity, namely diabetes. And that was a really big deal for a while. And just as Daryl is talking about, you know, 30 years or 40 years of changes in smoking, that's become relatively accepted that this not only hurts you, but it hurts me as well with secondhand smoke. How do you see, and you know, this is just a put you on the spot kind of question, how do you see this rhetoric about individual rights, even with mask or no mask, but going to questions of what I eat, when I eat it, where I eat it, and you know, do I have a right to sort of not maintain my health for my whole life and then ask the government to pay for that? And those are touchy questions, but we see reflections of it now with COVID, but we seem to have moved away from that. And I'm wondering what you see happening in the future on if this sort of messaging takes hold in public health.
As someone who teaches a class on the history of the cigarette, if you don't mind, Todd, I'll take a first stab at that one. One of the things about cigarettes, though, that's interesting, and you brought up secondhand smoke as an issue, is it becomes rights versus rights, right? So it isn't. And when you look at how policies changed, I couldn't agree more with Professor West that it has changed, and we have this attitudinal change that's huge. But when you look at how it changed, we have very little federal policy about cigarettes. We don't have comprehensive laws about cigarettes, except now that the FDA regulates since Obama time, but even that hasn't been that much regulation, right? When you look at how that happened, and it doesn't connect much to what we're talking about in the book, from what I can think. Like if you look at who's on what side, there might have been some rights talk for smokers, but then boom, you got rights for non-smokers, right? So it didn't become the same partisan issue that we're talking about here. So I'm not sure if it's exactly the example that I would go with, right? Obesity epidemic is a whole nother can of worms, right? So then the issues of stigma and how you make policy come up. When you think about harm reduction in general and public health, I think what you're talking about, sometimes you have Democrats and liberals thinking you shouldn't mandate things, right? At the moment with COVID and with vaccines, we've seen this, but you could go back to HIV/AIDS when mandating testing was something that liberals didn't like because it was harming people and it wasn't helping the policy. Or you could go back to pox vaccines in 1947. There are some famous articles about that by Professor Judith Walter Levitt and things, showing that it was voluntary vaccines that worked, not mandated vaccines. And if it had been mandated, people might have been running in the other direction, right? So some of that gets complicated when you start looking at those issues. But I'll let Todd go. Sorry.
I would add, I really like what Martha just said in terms of, right versus rights, and sort of how obesity, the obesity example is a bit more complicated. I think my past work on the history of heart disease, I think there's something to be said about uncertainty and risk as they relate to chronic disease management, and sort of this notion of how do we define and understand the relationship between sort of individual behaviors, especially sort of lifelong behaviors, and the physical manifestations of disease that may come years, if not decades, down the road.
Right, and I'll just, yeah, go ahead, Martha. No, go ahead.
No, just quickly to say, and it being an individual thing is very difficult, right? Because the sugar industry has increased how much sugar it puts into products, because poor people don't have live in food deserts and can't exercise. So the idea of the individual becomes really complex.
Exactly.
Yeah, and I guess in the question I was trying to sort of draw the parallel between what you're discussing in terms of federal programs mostly, and how much they cost, and how much they're going to cost more in the future, and what responsibilities we have. So, are there responsibilities that come with our freedoms? And you're right. We don't know if you will necessarily get sick if you engage in certain behaviors. We had probably stronger belief about that with cigarettes, but you could argue with diabetes that's coming to the fore. But so I want to go to one of the questions from an audience member, Mariana. Says basically, and this is for Kelly Smith, that we've been arguing sort of state versus federal since we started, right? Since we founded the country, and we went from an Articles of Confederation to a Constitution to create a union because we essentially were saying there are some things that we are willing to let the federal government control. And so from your neck of the woods, where do you see, as Professor West said, we may or may not get more progressive as a country as younger people who are progressive, certainly, and who have changing their personal habits, change what we think about healthcare. But as we move forward, do you see a resolution to this, or do you see just further and further division across states in the issues of healthcare? Or is it that everybody gets to an age where they get Medicare and so they're all for it? I mean, how do you see that working out?
That's a really good question. And I don't think that there is, an easy or simple answer that we would know at this point in time. But I will say, right, the danger, as you mentioned, Professor Schiller, the worry is that as states move further and further apart, we're going to see these, greater and greater differences in both access to healthcare, outcomes of healthcare policies, et cetera. Right. And that can be concerning in many ways. However, that doesn't mean that can't be overcome, right? So it doesn't mean that these state actors and political parties in the states are so constrained that they're on this one path towards separation and nothing could bring them back. And a good example of this is actually some work we were just reading in one of my classes about states opting into Medicaid expansion and looking at the severity of the opioid epidemic in certain states and how that was a contributing factor to some states kind of going against their kind of party leanings because they needed the federal money because the opioid epidemic was so severe. And so in some senses, right, if some states are experiencing it, and we know that states and localities are the ones that are feeling the brunt of these policy problems first. And they're the ones that are forced to try to come up and innovate with solutions because their constituents are affected first. So we know that, we don't know which states are going to experience obesity more severely in 20 years or any other type of epidemic. But, it is encouraging to see that problem severity in the policy world can buck the kind of partisan trends that we're seeing, and it can overcome this divide in some instances.
Yeah, that's a great answer in terms of trying to think about when Idaho, for example, and Utah and some states that are deemed sort of red states, have decided either by referendum or state legislative decision to go into the system. So
and I will add on to that, Professor Schiller, right? Remember that we have direct democracy techniques available at the state level. And so we do see in some instances health policies being passed at the state level through referendum or initiatives and bypassing in some ways the legislative process. And so we don't know how that will play out in the future as well, but we do have that available to us at the state level that we don't have, right, at the federal level.
Yeah, and I'm going to ask Professor West a question, but I wanted to go to Professor Hackey to build on this a little bit, and you could address, the idea of how we define a public health problem. So, of course, the tragic shooting in Michigan in a school, obviously yesterday, and we've come all too familiar. And you have an excellent chapter in the book on gun violence. And so, how do we define? When does it become a public health problem? How do we define it, and how does that work?
Well, that's an interesting question, Wendy, because I think one of the challenges here is that many of these definitions are really quite imprecise. A few years back, I did a book on cries of crisis, which is how we talk about the healthcare system through the lens of crisis. And similar to the conversation we're having here tonight, different parties have different perspectives on contested issues, but Americans across parties can often disagree. For example, malpractice for physicians is a crisis in terms of rising insurance premiums. For patients and other advocates for patient safety, it's a question of how do we reduce medical error. And so both sides can point to numbers that document the existence of a worsening condition, a crisis. But I think one of the things that is sobering is that we have lots of issues on our public agenda that don't necessarily get addressed. I think gun violence is exhibit A on that front. Certainly in the conversations we had with our students this semester, many of our students had not spent a lot of time reading about gun violence before our course module on this. And they were really quite taken aback by how little progress has been made, and frankly, how similar the conversation is. The conversation we were having after Columbine in the Clinton administration is very much the same as we're having in Newtown, Connecticut in the Obama administration, and it's pretty much the same as the one we're having today in the wake of what happened in Michigan. And I think we're seeing, contested issues here in terms of whose rights should prevail, but there are also important vested interests here. And I think that's something that is really important as well. Healthcare, in general, tends to bring a lot of important economic issues to the fore. We're talking about 1/6 of the American economy on a lot of these questions, and it is a knockdown, drag-out political struggle because, frankly, there's a lot at stake. I did want to mention one thing in response to Kelly's point, which I thought was an excellent observation about direct initiatives at the state level. This has been fascinating to watch with the Medicaid expansions, by the way, because states like Utah, where we had a referendum that actually passed and basically opted in on the Medicaid expansion, the state legislature turned around and then basically amended and refused to fully implement the voter initiative and actually scaled it back considerably. So there's a lot of back and forth here at the state level. But I agree 100% with Kelly's point, which is that voters and groups that are passionate about healthcare reform can accomplish things at the state level that they can't accomplish at the federal level. And for me, the classic example of that is marijuana. We're seeing widespread liberalization of marijuana laws around the country, but it is certainly by no means anything that is on the verge of happening at the federal level.
So that it's funny. We have a question. We had a question from Tony Levitas about Medicaid and about how much money it pours in and how much money states and localities spend on it, and how much gets done in terms of changing Medicaid at the state level to either expand or restrict services, what will be paid for, who will be eligible. So you touched on that. We might come back to that to get some more detail. I'd like to go to Professor West, or Director West, is a Freudian slip from the old days. We have a question from Alexander, and since you've written a whole book called The Future of Work on both how we will work and then also globalization and the impact of globalization, I have a two-part question for you. So one of Alexander's question is, so for future healthcare workers, people who are now studying in medicine, the people that Professor Gardner is teaching as well, you know, how can they or how will they, do you expect, shape healthcare policy, delivery policy, what they will be willing to do in terms of procedures, what they won't, and how will that change the medical community? And the second question has to do with globalization. You know, when we have companies, as you've written about, in terms of mobility, literally that if you don't need this sort of capitalized infrastructure, right? Well, you don't have to be in one place. You're a service provider. We see companies leaving California, going to Texas, for example. What happens to the healthcare availability for their employees? And will there be pressure from corporate America and some of these low tax states to provide better healthcare? Or is it not an accident that they're going to Texas, which has a pretty good major healthcare system? Will that be an incentive for states to keep up in their healthcare, because otherwise business will just not locate there? So those are the two parts questions I have for you.
Great questions, and you've hit on several of the drivers of the mega change that I was talking about before. So technology, globalization, the mobility of capital, the ability of companies to move across state lines, all together are producing a revolution. So to take technology first, technology is going to reshape healthcare across the board. Just in the sense of, we're already seeing consumer devices, you know, fitness checkers, step counters, things that monitor vital signs. People are going to use these things. They're going to electronically transmit symptoms and other health indicators to their physicians' offices. And it actually could put doctors and nurses in a position to become much more proactive about medical care. Like today, basically everybody waits until they get sick, then they go to the doctor, and then the doctor has to deal with cases, some of which are quite acute. If we can become more proactive about medical care through technology, and if we can actually keep people out of hospitals and doctors' offices, that will save a lot of money. So I'm actually optimistic about how tech is going to reshape service delivery, how it can empower consumers to take control of their own healthcare, provides access to a broader range of information. Like, you know, all of us do Google searches before we go to the doctor, so we can ask more intelligent questions and things like that. On the globalization and the mobility of capital question, I think what that highlights is the importance of redoing the social contract in response to technology change, globalization, and the mobility of capital. That in the same way that 100 years ago, we moved from an agrarian to an industrial economy, we had to change the social contract. You know, we developed Social Security, unemployment compensation, we adopted the income tax. There were a series of political reforms to make policy change easier. As we're moving towards a digital era and a digital economy, we need to redo our social contract. On your particular issue of a company moving from California to Texas, what that means is benefits need to become more portable. Like, one specific change we need to make in the social contract is there's going to be more movement of all sorts. Companies are moving, people are moving. We're seeing the great resignation. People are moving from company to company and job to job. Health portability, retirement benefits, portability of disability insurance, like all those things are going to be affected by all these changes. We need to make policy changes that help people regain access to medical care as these types of changes are transforming the landscape.
So that's a great answer, which of course, during your remarks generated a really interesting question from Khaled Abdo. We talked a lot, the question about the cost of healthcare and healthcare as a service, regardless of loss, it's needed. So how does framing healthcare discussions within the idea of markets and striving to be profitable shape public thought, or I'm going to ad lib here, expectation about healthcare? So one of the big question, I know we're not running out of time yet, but we're getting close to the end, and I want to make sure to get this question to each of you, which is to Daryl's point and to Colette's point. Are we getting to sort of not a Medicare for all per se as Medicare, but are we getting to, with the expansion of Medicaid and then possibly lowering down the eligibility for Medicare at some point, are we getting to a system where the vast majority of Americans are covered by a federal health care system or federal health insurance? And will we see the private insurance sector get smaller and smaller? And it's a loaded question. So I don't know if the authors of the book want to take it or anybody else want to take it.
Take a stab at it.
Okay.
I think certainly there is a growing push to expand both federal and state healthcare programs through shared programs such as Medicaid. But I think the private sector is going to remain a key factor here. Now, that's an interesting notion because for many, many years, companies have been concerned about the cost burden that they face. This is, as you think about rising burden of healthcare costs, it falls squarely on the shoulders of American companies when they compete globally. Because in countries with universal healthcare systems, those costs are borne broadly by the taxpayer, not by specific companies. And one of the things I think, to Daryl's point about mobility and mobilization of capital and workers across states and within states, individuals are often locked into jobs based on the health plan that they have, and that's not terribly productive in terms of making sure that individuals are able to realize their full potential. That being said, I think there's great opposition to any type of significant increase in the federal presence from the American health insurance industry. Now, that is not in itself a deal breaker. The American health insurance industry came to terms with the ACA, but I think there's a notable difference between that and, say, Medicare for all. Medicare for all essentially zeroes out the American health insurance industry. It doesn't really have a future there. There's one insurer. So United and Cigna and Aetna and all those other private companies that currently offer products to consumers don't really have a role there. And I think they came to terms with the ACA because the ACA promised them more paying customers. The employer mandate, the individual mandate, basically promised to move more individuals into their business model. So I think we've seen a lot of blowback against that, obviously, over the past 10 years. But I think that's going to be a significant area of opposition to any growing federal presence in terms of reorganizing healthcare. It's not that, I think Jim Marone had a wonderful piece a couple of years back in the New England Journal of Medicine, a short piece on Medicare for all. And Jim made the observation that everyone thinks that things aren't possible until they are. Sometimes we have to wait. These issues percolate and they develop over time, a momentum. I don't think we're there yet, but I think individuals are going to have to find ways to overcome that concerted interest group opposition to get a broader federal presence from at least in the short run.
Does anybody disagree at all? No, I'd like to disagree just a little bit and go back to a quick thing what Daryl said, which is that in the sense that you sort of grow up in a generation and you get used to what you do. And so in your 20s and your 30s, you're socialized in a certain way. Oh, do you get insurance? Do you not get insurance? You don't go to the doctor, you do. And then as you get more complicated in life, you want more services, right? That's an aging cohort effect. But if now most young people, at least from our experience dealing with them, live within their phone in every conceivable way, the days that they're going to be willing to bring this card to the doctor or try to find this bill or this record or get this exam result, all of it they're going to want at their fingertips. They're all going to want to be able to show something to a doctor in any state they go to and receive care. So in that sense, doesn't technology push the industry in terms of consolidation, whether it's private or it's public? Generationally, what you're used to frequently drives what you want to pay for, what you're willing to pay for. So in that sense, couldn't modernization and technology push for at least more consolidation across state lines?
Yeah, I can give a quick response to that.
I'm sorry, Daryl.
Yeah, go ahead, Daryl. Daryl, and then Professor Gardner, and then Bob, if you want to jump back in.
Yeah, I'll just give a very quick response to that. I mean, we're kind of used to a model of policy driving change and the government driving change, but the example Wendy gives is consumers driving change. And I think it's right that young consumers that have grown up as digital natives and they're using technology in all aspects of their life, they're going to demand changes from the healthcare industry. And certainly mobile health, telehealth, all of us during COVID have gotten used to video conferences with doctors as opposed to physically going into the offices. Like, these types of changes are here to stay, and in fact are going to accelerate over the next 5 years. So I think we will see a lot of tech-driven change in healthcare, and young consumers will certainly be demanding more movement in that direction.
Professor Gardner?
I could see that point about age, but I guess when I think of healthcare and how people get healthcare in our current society, I don't usually think people say, I'm going to push for what I want. They're going to say, what can I get and what can I afford? Like, at this moment, I don't see it framed in the way that we're talking about. That sounds more optimistic than I feel about the system. It feels like the profit-based system is pretty strong right now, right? And a lot of what we're talking about and the amount we spend on healthcare versus countries that get more for less makes me think it's not that logical. Like, I'm afraid it's not that logical. But I know less about the policy side than others.
So I didn't know, Professor Smith and then Professor Hackey.
Yeah, just a quick add-on to that is the kind of the problem, right, with maybe the consumer overcoming the concerted interest group pressure is that individuals have to recognize and see that the federal government's acting or not acting in a space. And I think for the average individual, the government's role in healthcare is a little bit more obscure and hidden than maybe we see as scholars in this area. And so without recognizing the role that the federal government already plays, like I don't know if individuals will be as mobilized, and I could be wrong, right? But not realizing the policy in the federal area, in the federal government, already might be preventative from individuals mobilizing against private insurers or other areas.
Wendy, I thought you asked a really good question. I've got 3 quick points to make about it. First of all, I think to pivot back to something that Kelly started with, which is the role of states. One of the obstacles to kind of consolidation and broader competition, if you will, on a national basis here is the role of state governments in licensing health providers. And that's very much a parochial environment. And it's kind of crazy that, a physician who's licensed in Rhode Island would have to have a separate license to practice down the street in Massachusetts. I mean, you could probably see the state border from your office in Pawtucket, but yet you can't practice in Seekonk unless you have a different license. We're starting to look at ways to deal with that. There are interstate compacts for mental health, for example, but that's a big barrier. And I think federalism is going to be front and center in that conversation. States such as Rhode Island are very concerned that other states might have less stringent licensing requirements, and we want to make sure that we maintain certain standards. The other thing I think about is consolidation, which is clearly happening in healthcare. We're seeing it in a variety of settings. CVS and Aetna merged a few years back. They're now a huge behemoth in the industry. CVS has got a footprint in lots of different ways. And to Daryl's point about transformations, I think CVS is positioning itself to be a lead player in a new marketplace. Their pharmacies are now an entry point for folks to access a healthcare system. And certainly COVID has accelerated that as more and more people use minute clinics and get vaccinations there, et cetera. They're hoping to be basically a first stop shopping place for healthcare. And one of the other last point I wanted to make, I do think you'll see this push towards greater digital use of healthcare records, for example. Clearly, that's something that is growing in demand. One of the recent developments driven by COVID is telehealth first primary care appointments, which many providers have viewed as a real positive development. You get to know your patient remotely. You access all of the files before you meet the patient face to face and lay hands on the person. So that's a good thing. But unfortunately, we've got a very fragmented electronic medical record system and national record keeping system. I mean, I think the classic illustration I would use about this is my wonderful cardboard COVID vaccination card. Unlike many countries with electronic health records, I've got a nifty throwback to the 1920s here with a COVID vaccine card that if you lose it, you're suddenly scrambling, how do I prove my status? That is really remarkable in a country like ours, but it's not unique to COVID. We have to kind of go back to that point about the marketplace raised by Khalid, I think one of the interesting things here is that in this healthcare marketplace, electronic health records, we don't have a single national vendor. We have multiple competing vendors in a multi-billion-dollar market. The key for the federal government has been to try to define something called interoperability. Basically, the systems should talk to each other. Well, they don't particularly well. And yet no one could settle upon a single national standard because no one vendor wanted to cede responsibility to the federal government for making that choice. And I think that's a big challenge for us.
So I know we're coming to the close of our time in discussing, and we could talk about so many of these issues. You raise the issue of healthcare records and consolidation of hospitals. We're going through that in Rhode Island. But the good part of that is that you go to your portal and you see everything from every provider. And so, you have less quote unquote choice, but there's more communication electronically. So I'd like to ask each of you one question to end the conversation about the book, Today's Healthcare Issues, Democrats and Republicans Across the Aisle, which is a terrific book. It's incredibly thorough and comprehensive and engaging, which is very hard to be all of those things in one book. So my final question to the panelists, and I'll start with Professor Olszewski and we'll go around, is what is the single biggest change you think COVID will bring, because I don't think we're through it yet, to our conception of government's responsibility on healthcare? So I'm going to go with Professor Olszewski first.
That's a great question. I'm sort of racking my brain in part because the pandemic, I think more than anything else, has best represents the impact that political polarization has had on public health communication and sort of mobilization in the United States, and sort of what role the government is to play with respect to preparedness, pandemic response, sort of supporting vulnerable populations, however they might be defined. So I think, if anything, the pandemic has sort of shed light on the fact that this is a question that we need to address. It's sort of this question of what role should government intervention play and to what degree is a question that we're sort of living and breathing now. And I think it's not a new question. And it's one where I'm not entirely sure if we will have a clear answer when all is said and done. but at least it will keep moving the conversation forward in hopes of driving us closer to some answer.
Thank you. Professor Smith, I'm going to go to you next.
Sure. I also think this is a great question and a hard one to answer. I would say that COVID has exposed just how important states are to health policy and other health policy in the case of COVID. I think as state politics scholar, we've always noticed that, but I think this has become a much more recognized role just across the public domain. And what I'm interested in seeing is that now that the role of states and their authority and their importance has been highlighted in COVID, I wonder if that's going to start to spill over into other areas where states already have a lot of authority and policymaking power, but they're not being talked about in a national conversation. And so I wonder if now that we've been primed to think about states' roles in health policy, if we're going to see this conversation spill over to other aspects of health policy as well.
Yeah, that's a great insight. Professor and Director West.
I would say there are three changes. One is COVID has accelerated technological change, kind of along the lines of what I've been talking about: telemedicine, video conferencing, remote monitoring devices. COVID basically moved what might have been 5 years of digital change into 5 months or even 5 weeks. Like, it just kind of forced us to adapt, even if we didn't want to. Second change is COVID has speeded up the FDA oversight and regulatory process. When you think about the speed both of the vaccine development and then the vaccine approvals, like, it was in record time, I think, on both fronts. And so I think the FDA has gotten used to the fact it needs to make decisions faster, like especially in rapidly changing public health environments. It's like the old cumbersome model just is starting to go by the wayside. The third and final change I would highlight is COVID just exposed systematic inequality, racial disparities, like just in COVID incidence rates, now in vaccination rates. I know when I went to get my first vaccine in DC, which is a majority African-American city, I went to a place that actually was in an African-American community, and 95% of the people were white. And we've just seen racial disparities explode throughout every aspect of this pandemic. And, you know, we have to get a handle on that, and we can all see how unfair that is.
Okay, thank you. Professor Gardner?
This isn't a direct answer, but it's the thing that comes to my mind, which has to do with experts versus lay people. The thing that I think COVID has really brought out is the lack of trust in evidence-based ideas that come from scholars and experts, right? So the amount of people who are okay with just coming up with their own idea about whether or not they can deal with COVID has been striking. I mean, in some ways, it's just laid it bare, just like the inequalities Director West was just talking about. But I think it brings to the fore a concern, right? Like, so what can we do in terms of health policy and health education if people aren't going to trust us? Where do they get their knowledge, and what can we do about that?
I think it's an excellent point, and I think you touch on a little bit, and I'll let Professor Hackey close this terrific panel, but you really do touch on the idea that, you know, public confidence is tough to begin with in government, but in a fast changing world where they have to change their recommendations, you know, it's like anything else, instability, Plato, go back to Plato, right? You know, habits, you know, people believe and they can obey the laws and they can be comfortable with it. But when you're changing everything all the time, it's very disruptive for most people. And it becomes hard to sustain your confidence. So I think that's hopefully something that will get better in the future. So Professor Hackey, you are going to close out this terrific panel.
Well, thank you very much. I think for me, one of the striking things is also about trust, but it's also the distinction in public trust at the state level versus the federal level, where we've seen state leaders enjoy higher approval ratings and higher levels of trust than their federal counterparts. And that was true during the Trump era. It's true under President Biden. For better or worse, in addressing a pandemic, we need a robust and active role for federal government and for public responses in general. The private sector can't handle this without public authority. The big thing that I worry about today is that the public seems to have far less faith in our institutions and in our leaders' ability to handle that. And I worry that that's corrosive because, I mean, I think back to the 50s, when we were rolling out the polio vaccine and Jonas Salk came out and said folks should get vaccinated. And there was widespread celebration. There were basically impromptu national holidays. We basically, businesses closed, people, shut their shop doors and went out in the streets and applauded and had impromptu parades because we had a vaccine. Today, the difference is just striking because, to Daryl's point, we've had extraordinary success in developing these vaccines, in getting them approved and getting them into arms, and yet the challenge remains really one of messaging and persuasion, which for me, I think boils down to a lack of trust. And I think that is our big to-do list item going forward.
Well, on that note, I think that your and Professor Olszewski's book, Today's Healthcare Issues, can go a long way, I think, because it really presents some really important, very objective descriptions and analysis of where our healthcare system is, all the different facets of it, the different programs that affect really from when you're born to when you pass away, the whole gamut of our healthcare experience, and in a way that also represents the Democrats and the Republicans in a way that people can really sort of dig into and think, okay, where is the common ground? What may the future hold? So it's a really terrific work. You're really proud of it. And I recommend everybody go out and get it and read it and assign it in their classrooms. So thanks again. Thanks to all of our panelists. We really appreciate it. Director Darrell West, Professor Kelly Smith, Professor Martha Gardner. I'm Wendy Schiller, Professor of Political Science and Director of the Taubman Center. So thank you so much for joining us tonight. And we hope to see you again in the future.